We will present today to you data that was collected through two IRB-approved studies that we conducted at the Phonar headquarters in Melbourne, New York. The first study was done in 2021, just after I started with Leo Cancer Care, and we were really worried about anatomy in the male pelvis between the supine and upright. At that time, I had a lot of experience and participated in a lot of treatments of prostate, for example, in protons, and you know about the small bowel and the proximity to the prostate. I was really worried about how that might change into the upright position. And then in 2024, we had to go back to Phonar, the headquarters, to scan many more cases, and that was a part of questions that the FDA posed to us in terms of upright versus supine. So in this IRB-approved study, we scanned 16 volunteers in 5 anatomical regions. What is important in the first study, we really just zoomed in on the pelvis. We wanted to analyze the prostate and the surrounding organs. But in the second study in 2024, we had to look at very large field of view scans because the whole idea was to analyze the anatomy over an anatomical region. We used that MRI data then also to generate synthetic CT data with the help of MVision, and always credit to MVision as a company. They were extremely helpful with the generating synthetic CT. And then we used the CTs and the MR to analyze the anatomical shifts in organ positions. And here we use several other people on contract to help us do that. And then also we developed comparative plans on the synthetic CT. So the anatomical regions covered is the liver, lung, head and neck, and prostate. And today we will not talk about the breast because we did not do the breast studies. Breast studies will limit you to females. All the other studies were equally distributed between male and female and all the other anatomical regions. But I do want to point out, as in red text there, we have numerous papers now already submitted and numerous papers in the works on how breast treatments will be done in the upright position and enormous benefits that we think we'll see from it. And in this regard, we need to credit Tracy Underwood in the UK and also Sophie Bos-Bouillard at CLB and other folks in the UK that did a lot of tremendous work in that space. So we ended up going to the Phonar machine. You can see there on the left bottom is a picture of the open MR machine with a patient or just an actor sitting in it. And then on the right, you can see how the machine can morph into anything from seated to standing to at any angle to supine. We ended up doing 159 MR scans, 58 in the supine position and 101 in the upright position. And you can see the distribution there between pelvis, head and neck, abdomen, intracranial. And then, of course, in the lung, MR is not good to be used for the large field of view acquisitions in the lungs, so we just do cine loops on that. Now, we then use this data as the 159 scans we used to study the changes in anatomy between supine and upright. And these were reviewed by practicing radiation oncologists for 101 out of these MRI scans. And Dr. Durkee and Dr. Lou on the panel was part of that review team. We developed specific metrics for each anatomical region, which again were reviewed by radiation oncologists, medical physicists, and dosimetrists. And in green here is just we found equivalence and some advantages for the anatomy in the upright position versus supine position. And these were confirmed by these metrics. Important one is that all the analyses corroborated the published data on anatomical changes between supine and upright that was available to date. Now, of course, this study is now a year and a half, 2 years old, and there's many more papers being published in the meantime. So let's go through these anatomical regions. We will not talk about breast this time, but let's look at the abdomen. So here's the metrics that we came up. So what we have here is 9 volunteers, 5 males, 5 females that we scanned in the supine position, and we scanned the upright position, and also at 20 degrees reclined from the upright position. The reason why we added 20 degrees is, and later on we'll talk about that, is that we have data from the Chicago upright system that was scanned at 20 degrees because that scanner is fixed against the wall at 20 degrees. Anyway, we looked at a couple of parameters here. The first one was the distance between the right and left kidneys. the distance between the most superior slice of the liver and the most inferior slice of the right kidney, the distance between the most inferior slice of the liver and the iliac crest, and the distance between the head of the pancreas and the iliac crest. Of course, we look at these differences in all three of the postures that we scan. Now, again, this is not an eye test. I do not expect you guys to read the data, so we have it summarized here. With me in the room here, I have Michael Kissek that did a tremendous amount of work for us to analyze the data and do the statistical analysis. And we will follow up after the white paper. We follow up with a peer-reviewed paper to be published that will explain all these statistical tests. But the first thing that we found, and we did not any moment expect that we will find anything, that the distance between the kidneys were not impacted significantly by posture. The first significant finding was that the liver is pulled downwards by gravity by 1.4 centimeter if you go from upright to 20 degrees declined, and 3.7 centimeters if you go from supine to upright. I said that other one the wrong way around. As you go from supine to upright, you pull down by 3.7 centimeters. Those data are statistically significant as shown in the green highlighted things there. The head of the pancreas is pulled downwards as well by 3.8 centimeter, but it was only really significant for the supine to upright position, and that's shown here on the right. And then there was borderline significance of increase in the distance between the kidney and the liver, and that's of course because I think the liver moves inferior as you go from 0 to 90. So this data then is supported by a paper that was published in 2007 by the team from PSI, Martin von Siebenthal. They looked at liver drift, and it was very interesting that they found if you lay the patient down, the liver keeps on changing position over a 35-minute window and up to 20 millimeter drift in the liver. So that it just shows again what can happen if you change the direction of the gravitational force, and you'll hear me talk about the gravitational forces a lot during this presentation. One important thing, if you start looking at the diaphragm in the liver and the difference between supine and upright, then yes, it's the gravitational force as well, but it's also when you're lying supine, there's really no specific draw in any direction, definitely not in the inferior direction from a gravitational perspective, right? There is an impact of the entire abdominal fluids pushing back into the diaphragm. We'll talk a little bit more about that when we come to the lung movement. So next one, we'll look at the thorax region, and I'm excluding your breast for you because I'm not going to cover breast in this talk. So this deals more or less with the lung. And here we looked at cine loops for 5 males and 5 females, and again, all 3 of these postures. And what we did is we took a sagittal cine loop through the lung, through the right lung, and we kind of standardized at a distance about roughly between 5 to 7 centimeters off the spinal column, just to find a plane, but it's also a plane that corresponds more or less with the apex of the lung. So we see the apex here, and then Michael did the analysis by putting a marker on the diaphragm, and then in the cine loop, using some fancy analysis to figure out where is this fiducial marker. What is very, very interesting, if you see for the same case here, in the supine position where you see a significant curvature on the diaphragm, but as soon as you go upright, the diaphragm is less curved, right? That's an important observation that we found through a lot of these studies. Here's a lot of the data that Michael presented. Again, I'm not going to present everything to you. Just want to see if you look at the excursion and amplitude for the patient in the supine, in an upright position, and you compare that with the amplitude in the supine position. So here, tilt 0 degrees means the patient was completely upright, tilt 20 degrees was off, and then tilt 90 degrees was 90 degrees from upright is supine. Then you can see that we saw a 67% increase in the excursion on average for the patients in the supine position, right? So the analysis of the box whisker plot there on the left just shows the Michael's analysis for one patient. Here we see a plot of the green bars is the excursion in the upright position. Then the yellow bars in this case is the excursion when the patient is just reclined by 20 degrees. And you can see not a significant change. If you plot the green bars again now against the red bars, which is in the supine position, then you can see that for this patient here, you can see a huge jump in the excursion between the supine and upright, but overall a significant increase. So what is important here is that from 0 upright to supine, there is a 67% increase in the excursion that is significant. And that was borderline significant from 0 to 20. Again, we would not expect a big change. And you will hear me talk a lot about this, is that the 20 degrees was actually quite a difficult angle to image, and often was going, there was some pushing on the patient, and a patient kind of seated in a crushed position, and it's not was really comfortable. But this was the finding, which is important, from a complete upright position, which was pretty much done in a standing position, to supine, a huge change in excursion. What was really interesting, that the breathing period was not significant. The change in the breathing period was the same, whether you're lying down or upright. That was interesting finding. Again, this data is then 100% corroborated by a paper that was published in 2013 by the group from namely Anderson under leadership of Lawrence Court, where they studied 5 patients, and it was actually at the same phonar scanner, but they found a significant increase in lung volume on average, but they also found, as shown in the graph here, a reduction of about 4 millimeter in the excursion on average. So what this actually means is that if we see that there's significant reduction in excursion, that means that a lot of patients in upright position would probably drop into a scenario where we do not have to do motion management because the total excursion is less than 5 millimeter. And this data has already now also been supported by early work done by the folks, the PQ folks in Israel, where I talked to Dr. Zelik Talkner, and he basically was already saying that he does see a significant reduction in excursion upright, which means lung treatments upright could be easier. There's another hidden benefit, that image quality will be better if the motion is less, right? Here's such a paper that also support lung work in the upright position by Matsumoto and from Dr. Yansaki's group. Just a couple of findings here where it was just general. I don't want to bore you too much for the data. Just want to show this data corroborates that everything was kind of better in the standing position. The average luminal areas of the trachea, right, left, and main bronchial airway were greater in the standing than in the supine position. The forced expiration volume was higher in the upright position, and that was also proven and shown by one of our PhD students, Anthony Cruzcolo, that showed he did spirometry studies in the supine upright position, and he showed that it was the FEV was larger in upright position. So we did not do much more in terms of that, rather than the motion studies. I think we'll get a lot of data coming out of that. The next anatomical region we'll talk here about is head and neck. And here is where we use Dr. Durkee to help us with analysis. And again, the work was done by some of radiation dosimetrists that worked for me, and then Michael did the statistical analysis. So we just came up with a couple of metrics here and say, can we get some information of the size of the tongue? So that's the measurement A there in this diagonal direction from the front of the tongue to the back. I thought that the tongue would significantly drop to the back of the throat in the supine position. And then we also looked at the throat opening. There was measurement C, D, and E there, right? Again, lots of data, but I'll just summarize the findings here. We did see a bit of a change in terms of the A and B parameters. So that's the tongue. So we just go back here. A and B is the shape of the tongue. Kind of saw that there was a little trend for the 0 to 20 had the biggest movement, but overall was not statistically significant. And I think this thing that we saw more of a change from 0 to 20 probably had to do with that positioning technique. And people that hasn't experienced it wouldn't really understand it, but it's very difficult to set that patient up at 20 degrees, and then we still have to have the MRI coil in a head and neck immobilization. And so I think there was just a lot of strain on the volunteers to do that. I was, of course, one of the volunteers. That's why I can testify. But what was really interesting in this case is that we did not see the throat opening airways to change significantly. And again, here we might just be dealing with motion, and the study is not done well enough. I mean, I think there's a lot of other evidence that the airways are open. That's, as I just said earlier, with the forced ventilation, the FEV parameter, right? So this would take more study, and I would like to hear what Dr. Durkee would say about this. And we have a lot of feedback from physicians that believe that the upright is the really preferred position for head and neck cases. One of course, the benefits that saliva would just go down under gravity and less need to swallow in it. Intracranial is part of the head and neck region in this presentation, and we did one male and one female for the intracranial study, but it just turns out that because we needed to study a large volume times the differences, we do use that data only for comparative treatment plans. But at the same time, this paper was published again also from Professor Yansaki's group in Japan, where they have an upright CT scanner. It's a Canon scanner that was mounted upright. You see on the right here, and the patient can be seated or standing for treatment. They've done an enormous amount of CT work upright in supine. I'll just summarize a couple of findings that they did here for a very intensive study inside the cranium only. And they found the pineal body shifted by 0.6 plus minus 0.3 millimeter in the ventral direction. And 0.6 millimeter in the caudal direction. So again, it's less than 1 millimeter, so one can say no problem there. The length of pituitary stalk decreased by 1.2 millimeter, very little. The cerebellar tonsil descended by 2.1 millimeter. So again, you can see everything here in the brain is kind of less than 2 millimeter. The lateral ventricular volume decreased by 5%, and they basically concluded that changes in the shape of the CSF spaces with changes in the posture were observed. Conclusion here then basically is that intracranial structure does move very little, but it just means that, as was done in the very beginning, where people say, intracranial, you can just scan supine and treat upright because the brain doesn't move. They did find some movement, and the conclusion anyway was you really need a CT scan in upright position to delineate structures. So again, with Leo Cancer Care having a diagnostic quality upright CT scan, that should not be a problem, and to register the images and do the delineation of the critical structures. Right. Next anatomic region is the prostate region. Here, I will just present to you some data from my first study in 2021. This data is now published in a peer-reviewed paper. Here we can see one of our staff members in the OPAR MR scan. I just want to point out here that in this case, we did support the patient's knees on a knee support and an armrest. But other than that, there was no other immobilization for this study. So we scanned 15 volunteers in the supine position with a full bladder, and we also scanned them in the upright position with full and empty bladder in the phonar scanner. So this pelvic study had a couple of great findings. The first finding that was examined was the position and shape of the prostate is not impacted significantly by the bladder flow. Distance between the sacrum and the anterior bladder wall is significantly smaller. So that channel where typically you would see the small bowel comes through in the supine position that channel is narrower. And the anterior posterior length of the bladder and the bladder width is significantly larger in the upright position. The seminal vesicles are pushed down by the bladder because the bladder is almost acting like a bigger umbrella, pushing everything down in the inferior direction. And normal breathing motion does not transfer significantly to the prostate region. Now, these three things here, the shape of the position of the prostate not impact bladder flow, was statistically significant, and also the distance between the sacrum and the anterior bladder wall. So these are very, very important parameters for upright prostate treatments. Why does this happen? And again, here we can see the impact of change in the gravitational force direction in the supine position. The gravitational force, of course, still downwards, but the abdominal organs are now all can go in any direction in the inferior superior direction. As soon as you go upright, the gravitational force now forces down into the pelvic triangle, and here you can see how the bladder is elongated in the 8P direction and flattened out. And This is a cine loop that we did on one of the volunteers. You can see on the left is the motion, the free breathing scan for the patient in supine position or the volunteer in the supine position. And you can see that the breathing motion, this free breathing motion, comes all the way down to the rectum. It's not clinically significant movement on the prostate here, but it just shows that free breathing motion comes all the way down to the prostate level. If you go to the picture on the image on the right, then you can see that motion is now completely nullified in the prostate region, and only above the bladder is where you would start seeing free breathing motion impacting it. So I think this will lead to extreme high quality images in the upright position because the breathing is happening further upright. So I'm really excited about where, because of this breathing motion and changes of bladder fill and changes of rectal content, makes abdominal treatments extremely difficult in the supine position, but I predict that this is going to become the easiest anatomic region to treat upright. So here again is then data that we did now on 10 volunteers in addition to that study of 2021, where we looked at 5 males and 5 females, and here we just scored the similar metrics, the distance of the tip of S1 to the bladder neck, and then the distance between the bladder neck and the apex of the prostate. In the male cases, in the female, we studied that same distance between the S1 and the tip of and the bladder neck. And again, a lot of data here, but we found the same thing, that the distance between the tip of S1 and the bladder neck is significantly increased when you go to the upright position, or decreased when you go to supine. And the anterior to posterior bladder is the same. Increase 80% smaller when you go upright, when you go supine, and the axial bladder width is also decreased. So the results are consistent with previous work of my paper in 2022. Gravity does pull the bladder and everything away from S1, and that just shows the increased gravitational force into the pelvic triangle. And the gravity also tends to widen and flatten the bladder when upright, and that has that impact of pushing everything more towards the prostate and anchoring the prostate. So now, how does these anatomical changes that we observe in these regions then transfer to treatment planning? And here, again, MVision was very helpful to us to help us calculate synthetic CTs. And here you can see a beautiful synthetic CT on the right from a brain MR scan. This is a case for a pelvic, and the data that MVision was able to create was wonderful, helpful for treatment planning, because we were really only interested in geometry and size and everything. But they used trained models that was not really trained for the 0.6 Tesla MR. So that was really helpful for them to be able to do this work and bring to us data that was usable for treatment planning. Nevertheless, we did 64 data sets that was converted from MRI to CT scans that we were able to do comparative plans on. The plans were reviewed by practicing radiation oncologists, and again, Dr. Durkee and Dr. Blue was part of that team. And we basically demonstrate the equivalence between supine and upright planes for all anatomic regions by these studies. So we'll just go through a couple of cases here in the pelvic region. We did in the male pelvis recurrent rectum, prostate, and bladder. And the female pelvis, we looked at the recurrent rectum, uterus, cervix, and bladder. We make 18 plans, and that reviewed by physicians specializing in the pelvic region. All the upright plans for the pelvic region were equivalent to the supine plans. So again, what we did here is we used the Mevion planning system. And again, I have to give credit here to Rocky Owen, did a lot of work for us using the Mevion system on this data, and just basically calculate the supine Mevion plan. And then in this case, they used the Mevion Gain3B model. And then in the upright case, they used the Mevion FitB model. We concluded here that hydraulic pressure exerted onto the pelvic organs are increased in the upright position, which results in improved pelvic organ stability. And then a really interesting finding here was that the dose-to penile bulb was lower for the upright prostate plans. And in my study, in the 2022 study, I didn't put that in, but we did study the position and actually the distance between the penile bulb and the apex of the prostate is larger in the upright position, which is kind of counterintuitive. One would think the prostate pushes down, but it has to do with the posture and the abdominal anatomy in the supine position. Again, it's not large, but the penile bulb, of course, sits in the penumbra of the beam, so a small distance shift caused significant decrease in dose. In the abdomen, we looked at head of pancreas plans. Of course, these were all just fictitious plans. We had to try and find an organ and see how to do it. Here you can see the supine plan and the upright plan, and then the plan at 20 degrees tilted towards off the vertical plane. Look at the liver tumor and lower pole of the kidney, and then head of pancreas, liver tumor, and lower pole of the kidney for male and female, the abdominal space. And again, these plans were then reviewed by Dr. Gray from the Proton Center in Nashville. And again, all upright plans for the abdominal region were equivalent to the supine plans. The gravitational pull on the abdominal organs will help with organ stability and reproducibility in the upright orientation. The abdominal organs like the liver, duodenum, and pancreas are pulled in the inferior direction for upright positions by an average of 4 centimeters for all 9 cases evaluated. So that's a significant pull. Now, if you think about it, you see that change in direction. I postulate, I don't have any evidence that right now, but I do believe that will result in more stability. For the intracranial cases, we just looked at a large frontal lobe tumor and then also a whole brain treatment, which is typically what you would do for CSI. And these cases were reviewed by Dr. Mehta from the Miami Cancer Institute. For the head and neck cases, we looked at one male head and neck and one female head and neck, and here we look at nasopharynx, sort of submandibular gland treatment in the head and neck case, and these were reviewed by Dr. Durkee. Again, all upright plans for intracranial head and neck regions were equivalent to supine plans as adjudicated by these physicians. No significant anatomical changes were observed between supine and upright for intracranial cases reviewed. Minor positive benefits observed for upright head and neck plans, and Dr. Durkee could opine on that, and mainly improved tongue position and more open airways, as we discussed earlier. Right. Then here it was a really interesting situation that in order to get information about the thorax region, we looked at plans and data that we received from the folks in Chicago, where we looked at 16 thoracic plans, and here we just compare the patients that were scanned in the upright position, but they were actually treated in the supine position with the IBA machine. So we took the plans as treated with the IBA machine and then recalculated them in the upright position with the Merion Fit B model, and had Dr. Liu and Dr. Harsel review these cases for us. There was also, in the female case, also mediastinum with 2 right lung cases and 1 left lung case. Go back here in the male cases, there was 2 mediastinum, 1 posterior chest wall, and 1 left lung case. Right? And again, all upright plans in the thoracic, for the thoracic plans were equivalent to the supine plans. So again, the supine plans was delivered on the IBA machine as they were treated in Northwest and in Chicago. Significant improvements of heart position for the upright case were observed in 1 case. There was a really interesting situation, and I'm out of time. I'll stop here in a minute. In that case, the heart actually rotated away from the lung in the upright position, totally rotating the LAD out of the way, and that resulted in a very low dose of the LAD in that case. So that's just one example. Of course, we are a little bit biased, so a result like this is always nice to see. But what we found, again, the lung superior to inferior length is significantly longer in upright position. Right? So I'll stop here and hand over to Kate to facilitate further from here.
So one of the questions that we did already have through was, did you observe consistent anatomical shifts across patients, or was there high variability?
So we have all the statistical analysis, and if there was wide variability, then of course we typically would have resulted maybe in not statistically significant. So that's why we stress out the statistical significance or not. So in the cases where we claim statistical significance, then yes, maybe variability, but certainly in a certain direction. And some cases where there was no statistical significance just because the standard deviation was larger than the shift, perhaps.
Were any findings unexpected or counter to common assumptions about upright positioning?
Yeah, that's a very good question. Of course, we are biased, and of course we would like to see the data. But I would honestly testify that when I, for example, started, I said no ways that the prostate is going to turn out better. So it was unexpected for me that the prostate would be so much, or the pelvic region would be so much more stable. And also, I want to say that there was absolutely zero data for the male pelvis available until we started doing this study. So that was a really good positive finding. Of course, we were happy to see that outcome. I think the rest of them are just coinciding. The one that I am disappointed on that we were not able to see a very clear indication that the tongue is in a better position upright than supine. That is the one parameter I thought was disappointing for me not to see that very easily observable shape of the tongue.
Ben, what were your observations when you were reviewing the data?
You know, well, first of all, thanks for having me. It's good to be on here. And I think you said earlier that there are 210 registrants on this meeting, which is absolutely phenomenal and really emphasizes the excitement here. You know, when I was going through this, I was humbled by my inability to predict where the changes would occur, and how much variability there was, between the local interdependence of, adjacent structures. So sometimes you think structures are going to, move together, and they don't. They separate to adjacent OARs. Sometimes they do. And I guess I was also humbled by what a challenge it is to quantify the changes between upright and supine. I mean, these are linear measurements, but what's really happening is deformations and, things shifting relative to each other. And so it's a really interesting problem. And it's something that you can capture quantitatively, like you understand, for example, the separation between a base of tongue and a posterior pharyngeal wall just by slicing through on the axial scans, but to actually measure it in consistent slices is a challenge.
Bill, what do you think clinicians and cancer center leaders should take away from this study that Niek's presented the data? What do you think the key takeaways for them is?
Sure. Well, I think just to give a little bit of background, my involvement in this was to be one of the reviewers for treatment plans comparing upright to supine, specifically in the thoracic region, because that's my clinical area of specialization. And the purpose of that study actually was to contribute to the FDA clearance of the Mevion S250 FIT system, which is an upright proton therapy system that is now being completing its installation here at Stanford. So that's going to be the first installation, and it's in the upright position using the Leo Cancer Care Patient Positioner. And so one of the questions from the FDA was how the plans compare between the supine and the upright position in various body regions. And as Niek mentioned, the data for that particular section in thoracic came from the Northwestern Medical Proton Therapy Center in Chicago, where they have both supine and upright positions for proton therapy. And there were 10 patients from their center that were treated in the supine position, but also had matching upright scans. And so those upright scans were used to regenerate plans using both an IBA machine beam model as well as the Mevion S250 FIT beam model. And the bottom line, as Niek already summarized, was that there were, really the plans were equivalent, regardless of the treatment machine beam, parameters and the positioning. When we looked at the doses to the targets, the coverage, as well as the normal organ doses, primarily looking at the dose volume histograms, that the plans were really equivalent. So I think that was a question that the FDA had, and I think it's a question that a lot of clinicians may have is, in what circumstances or how different might the plans be? And at least in the scenarios that we evaluated, and specifically the thoracic cases, we did not see a significant difference, which was encouraging. I think we didn't evaluate in that, but Niek presented some data on were the trends towards decreased excursions in the thoracic region with breathing in the upright position. So we didn't specifically look at that in this dosimetric analysis, but that has been studied previously.
And I'd probably like to go to each of you and just ask what you're most excited to be investigating next. I know, Niek, you said about tongue positioning was something that gave you results that we weren't necessarily looking at. So just which area of research do you think we need to be focusing on next, and which do you think is going to be sort of the most exciting to be really looking at in a little bit more detail?
Yeah, I'll take a stab at that, and I'll give it to Bill. Bill's such a futuristic thinker, so I'm curious to see what he says. But when you think about upright therapy compared to our usual supine therapy, we have 50 years of experience longer treating patients supine. And now all of a sudden we have this ability to, treat patients upright, which means different anatomic difference, different, intrafraction motion implications, different physiologic differences, and then differences in how we, set up our clinic and in terms of workflow and risk to our therapists. We're pulling the patients off the table, and risk to patients who are, get orthostasis sometimes getting up off the machine. And so I guess what I'm really interested in is, rather than a study or a particular data set or a particular registry, something actually less structured. I'm really excited to hear the narratives and the qualitative patient and user experiences. What's this like? And my guess is that's where it's going to uncover like some really cool things that we don't even expect.
Yeah, so I would agree with exactly what Dr. Durkee said. And I would say that for me, I think the exciting thing kind of comes in two phases, right? So there's a short term and there's longer term. In the short term, really the most exciting thing for us here at Stanford was that being able to achieve this ultra compact geometry was enabled by adopting this upright paradigm. And so for us, I mean, I think the exciting thing is this was the only way that we were able to bring proton therapy to our center and to our patient population. So just being able to offer this to our patient population is very exciting. And it overcomes a tremendous, practical problem. So that was actually the driver of this was the practical problem of making proton therapy accessible. And as Dr. Durkee said, I think a lot of the things we'll be learning in the near term are how to make the best use of this platform, because it is new. The workflows are new. The clinical setups, positioning, all of those things are going to be a learning process. And so I think that's, in the near term, the exciting thing to figure out and hopefully disseminate to other centers that are now starting to adopt this model. Longer term, I think there's a lot of exciting possibilities that are created by this patient positioning. For one thing, it really facilitates a lot of these newer geometric possibilities. For example, arc deliveries, or even more complex trajectories, helical, and you can think of a lot of different possibilities. Those have some potential dosimetric advantages, not only in the physical dose domain, but potentially also in how to optimize things like the distribution of LET and biologically optimized dosing. So I think that just scratches the surface of, the possibilities that we can start to explore.
Yeah, and I would just say for me personally, was this finding about the pelvic stability, and please don't think I'm just taking prostate here. That also translate to GYN cases, and we all know about the horrible tragedy in low and middle income countries where the pelvic. I mean, even though I'm originally from South Africa, there's still some challenges with GYN cancers, and patients get treating with four-field box treatments because of the organs move so much. So I'm really excited about going in direction where we can see a paradigm shift in organ stability in the lower abdomen pelvic region. But as Dr. Liu said, is that by now just rotating the patient is rotating a 100, 200, 300-pound patient compared to a multiple tons of metal to get the beam in different directions. So that's lower pelvic, and we can talk about many other cases is my biggest excitement. I hope there's a ton of questions from the audience, and I just want to say that the white paper that you will announce later on does have a lot of initial work. Then please feel free to come back to us with these specific questions. Let's see if the audience have some. I of course have always a ton of questions to Dr. Liu and Dr. Durkee.
So one question we had was, do you see upright MR still being used in the workflow when you have a CT at the treatment site?
I guess I would say that the main workflow in radiotherapy historically has been based on CT, right? We use MRI to supplement that information in a lot of cases, and it's valuable for that. So I think it's likely that there would be value in supplementing our both our targeting and kind of our treatment planning strategy with MRI, and in some cases having that match the upright position may be important.
Yeah, I would just supplement this. We did publish a paper also in 2022 to discuss the methodology, and again, the fact that we can now calculate synthetic CT from MR or synthetic MR from CT is actually, the timing is this incredible, because you can calculate the missing modality if you want to facilitate intra-modality registrations. So the current proposal, and we will start validating that soon at Stanford, Dr. Liu's guidance, is to see if you have a supine MR and you need that supine MR into the upright space, then what you would do, you would calculate the supine synthetic CT from that MR, deform it into the upright CT space that you have from the scanner, and then apply that deformation matrix to the supine MR, and that will deform the supine MR that contains all the information. It will deform it efficiently and effectively into the upright space in the region of interest. So I am excited. It is a peer-reviewed paper. It was reviewed by many folks, and anybody interested in that specific methodology can also, we can make that paper available. It's of course available. It's an open access paper. So to bring the supine MR and the supine PET into the upright space is actually not as much as a challenge now with the availability of synthetic generated missing modality.
I wonder. Another question we have is, do you have any insight of the reproducibility of positioning, OAR, stability, interfractions over the course of treatment in upright position?
Yeah, maybe I'll just jump in. There was a great paper published by the folks at CLB by Sophie Bos-Boubiar that looked at, again, pelvic positioning, and they found it was pretty well and pretty stable. Again, we would claim that we can do it. We have to do a lot more work, and as we start developing the first patient treatments, this is, of course, a very important aspect to continue to study. I would not claim that we have solved every issue in terms of immobilization. There's cases where we have to still improve immobilization, but what we're starting off is, it's actually very important that Leo Cancer Care's upright positioning system is not an afterthought. It was a machine that was designed from day one for upright positioning. So the shin rest that holds the patient, prevent the patient from slouching and sliding and all that stuff. So, but overall, I believe that the gravitational pull on these organs will result in organ stability and organ reproducibility, but we do have the CT every single day in the treatment position. So I do also want to see that we push the paradigm for adaptation on a daily basis to correct for setup variations. But it would be good to hear Dr. Liu's perspective on that, and Dr. Durkee.
Sure. Well, I think that that's an important question that we'll need to evaluate, what the interfraction stability of organs will be. So I think there's still a lot to learn about that. I think a couple of things, though, that I think possibilities that are created by having the upright CT built in, is that we'll definitely want to explore the potential for daily adaptive treatment planning, which can be facilitated by having high quality CT at every fraction. I guess another comment I would make is that the thought of doing upright treatments is a little unfamiliar to many of us in our field these days. But in fact, the history of upright therapy goes all the way back to the beginning of medical linear accelerators at Stanford. The first publications on prostate radiotherapy by Dr. Bagshaw, that was kind of the birth of prostate radiotherapy. That first series, the patients were treated using patients standing on a rotating platform and doing upright arc radiotherapy for prostate cancer. That was the first way that prostate cancer was treated with radiotherapy. So we're sort of rediscovering, the upright paradigm, and in a new era where we can learn a lot more about it. We have a more stable positioning platform and better imaging, and I think the opportunity to really optimize that whole paradigm going forward.
Bill, I always appreciate how you put it in the historic context. It's an exciting point in time, but it's just one point in time along a progression of advances upon advances.
And another question from our audience, I'll try and combine two of them here. So they were asking, were all the plans simulated for protons or photons? And then another question was, does RaySearch support upright treatments? So the two of them are somewhat linked there.
Right, yeah. RaySearch, and I have to give credit to the RaySearch folks who saw the vision, and I've been in discussions with them for a long time. Historically, the folks in all the ex-Procure centers, basically Chicago and Seattle and New Jersey and Oklahoma, did a lot of upright treatments in the early days. And RaySearch, when they entered into the proton therapy space, already started working on supporting those upright treatments, but not on a full-fledged integrated manner. And then came RaySearch 2021 A/B in that time frame. From there on, upright was fully supported for proton treatment in the upright position. And today, everything is 100% integrated. The RaySearch, the CT from our scanner comes straight in, handle the upright posture correctly, and it's fully baked in for upright treatment planning. And of course, now we're working with RaySearch also to integrate the upright X-ray photon planning for the Leo Grace machine. So I'm not sure I've addressed everything there, but treatment planning is the least of our worries at this point. Would have been a massive problem if RaySearch was not proactive to developing the upright component in the RayStation.
Niek, I'll echo and amplify everything you said, and major credit to RaySearch. It's a gutsy move for them going after and putting in as many resources as they have into a developing market. But as far as I can tell, they're light years ahead of anywhere else, and they're still going strong. And that makes the field so much more exciting.
I think we've come to the end of our audience questions. So is there anything else, any observations of the data while you're looking at that you wanted to talk a little bit more about, or anything else you wanted to share before we conclude the session?
I I have a question for the Durkee. Do you mind sharing? I mean, you talked a lot about it, but one day I was really worried about this whole thing of how you're going to delineate the targets in upright position if you don't have the precise MR in that place. And you explained to me how you would just follow the NCCN guidelines and study the anatomy in the supine and then be able to transfer it into the upright anatomy. Could you put some light on this, explain a little bit to the audience what you explained that day to me?
Can you, I'm sorry, I'm not recalling the conversation. It was a question about contouring, how we contour. Is that right?
Basically following the NCCN guidelines, or how do you have to draw that target and the margins and expansions, right? So what I derive from you is that you know what you want to treat based on your supine MR, and now you have the great anatomy in the upright position from the CT, and to what extent would you be able to transfer that information into the upright space?
Yeah, I I don't recall the exact discussion, but I think at the core of it is in terms of how we start with treatment in the upright position, you start from a foundation of what you already know in supine. And so I think the place to start there would be with all the same contour maps that you're already familiar with, anatomic based landmark, and the setup margins that you're familiar with. And then from there, start adapting to what you're learning about, intrafraction motion and interfraction motion.
Yeah, I would just add to that. And again, anybody interested in this data, when we started doing this, I made a spreadsheet where we took all the anatomical regions and say, in what region do you need MR? In what region is MR convenience? And what area is absolutely essential? If you start unpacking the entire problem, then this problem is not so massive. But again, that led us to write that paper that I referred earlier to, of how you would synthesize the missing modality.
I think one other thing I might add, an interesting possibility that is created by having diagnostic quality CT integrated in the system, and particularly the speed of the scanning that comes with that, is that we can do IV contrast enhanced CT scans. And that can be done not only for simulation, but it can be done even on a per fraction type of basis, or every few fractions, and so on. And again, facilitate things like online adaptive or even offline adaptive. But the information that's added, the anatomical information that's added by the contrast, can be quite substantial.
Well, I think we've used up our time, gentlemen. We've come to the end of the session. So thank you, everyone, for attending the webinar. As I said before, we will send out the recording of the webinar to anyone that registered. And also we will send out a link to the white paper that collects all of the data that we've presented today. And thank you to Niek for presenting it, and our two panelists as well for being part of the discussion, and for their expertise that helped get this data analyzed and in a position where we could share it with the world. So thank you, everyone, for attending.
Thank you.
Thank you very much. It was great talking to you, Mary. Thank you.